Thanks very much, Julia, and thanks to the organizers for inviting me to speak about this. So I have these conflicts of interest, but this is a very general talk, and none of them are relevant. I'm going to deal with this as though we were having to treat an individual patient who had arrived in our ICU, and the traditional questions we would ask are, what are the age of the patient? What is the GCS? Is there a surgical lesion? Is the ICP high? The patient gets past the acute stage, what happens when you stop sedation, and then what is the functional outcome at 6 months? Now, the last question is not something that all ICUs ask. We traditionally, as intensivists, used to looking at just mortality, typically at 28 days, but now increasingly at 90 days. But I would very strongly encourage you, as will become obvious over the course of the talk, that we really have to get functional outcomes on these patients to understand what we're doing. So this is how patients seem to go through the system. They come in, we see what their GCS is. If it's 8 or less, they wind up, if it's greater than 8, we may consider clinical monitoring. But if they are obtunded, they wind up getting an ICP monitor. In either case, if they have an operation for a surgical lesion, they will either go to clinical monitoring or ICP monitor after that. At that point, when we're monitoring them on our ICU, the ICP may be stable, they emerge from coma and we get them back to clinical monitoring, or they have refractory ICP and they go through the tiers of therapy, and when the ICP is stable, they go through the system and finally get to being extubated. And they'll either go to rehabilitation and then we have an outcome. Some of them remain in a disorder of consciousness, luckily it's a very small number, and some of them die, a reasonably large number in the ICU population. So this is the situation that we've had so far. But over the last 10 years or so, with large observational studies, center TBI and tract TBI, we've had additional insights about how these patients should be treated. And that's built on our understanding of what are the prognostic factors we know affect outcomes. So this is work from Hester Linksma. This is now nearly 15 years old. And the demographics, essentially the age of the patient, accounts for about 8% of the outcome. The clinical severity, essentially the GCS, brings that up by about 20% or so. So now you're cumulatively at about 28%. The presence of secondary insults, hypoxia, and hypotension adds to that. The CT characteristics adds to that. And then you have a little bit from laboratory, predominantly hemoglobin and blood sugar. But even with all of these included, we can only explain about 35% of the variability in outcome. So clearly, there is opportunity for improvement. And these opportunities include better phenotyping, blood biomarkers, better neuroimaging, either MRI or quantitative CT, and potentially genomics. So there's a set of new questions that are emerging. One, is this a high impact or low impact injury? What is the influence of frailty and pre-injury comorbidities in our older patient population? Is there CT occult prognosis-defining injury, typically diffuse axonal injury? When we're treating these patients, ICP, are the elevations more harmful or is the treatment we're giving them more harmful? And corollary to that are the desperate tier 3 therapies, decompressive craniectomy, barbiturate coma, hypothermia, justified based on outcome, personal choice, and recovery duration? Is late emergence from coma drug responsive, and what's the outcome at an even longer time point? So here's the data from Center TBI and PLOS Medicine on what happens with high impact versus low impact. We've traditionally thought of these high impact injuries as really the bad ones to worry about. But this is low impact injuries occurring typically in older patients. And you can see that they form a large number of our patients on the ICU. Their median GCS is actually slightly higher. They have a similar proportion of abnormal CT, and this is well recognized in a paper published by Fiona Leckie, because the increased amount of space in their head means that an equal size hematoma may not cause as much intracranial hypertension and a relative reduction in the amount of GCS compromise they have. They wind up having exactly the same number of interventions despite apparently having less severe injury, and their mortality is much higher. So this is to do with age and impact, but there's also this really nice paper from Giuseppe Citerio based on the Center TBI data, which makes the point that it's not just age, it's also frailty. And I think it's useful to think about frailty as the BMI of age, just like we don't just take the weight of a person, we say how tall is the person and then calculate the BMI. Frailty is a way of conditioning our estimation of age. And the more frail a patient is, the more likely they are to have a worse Glasgow outcome score. So the upshot of this is that the GCS underestimates brain injury in the elderly. The low energy cohort are 50% less likely to receive critical care even after adjusting for severity. So the inferences are, we need to account for frailty. We need to understand that the energy classification system that's used in pre-hospital triage is not really accurate. And then we need research on whether this 50% lower ICU provision in the cohort is appropriate. And we need to emphasize TBI prevention from falls, not a problem for us, but for the system. The second thing that we have is a whole host of biomarkers, and I don't have time to spend on this. I had a talk on biomarkers earlier. The ones that are reaching dominant usage are GFAP, glial fibrillary acid protein, neurofilament light, and perhaps UCHL1 and tau. But it's really important to make sure that the biomarker used takes account of kinetics. Some of these are acute biomarkers. S100 and UCHL1 are really sharply rising and may have benefits, but also biomarker sensitivity, and GFAP tends to be a really good analyte and probably will win out. We don't know for absolute certain as yet, but probably. We need age-appropriate norms because NFL, for example, is very high in toddlers and as you grow older, and also is elevated with comorbidities. And we need to think about the time to result because in research studies, the samples go away and the results come back after typically months. But to act on these, we need results back in hours rather than days, weeks, or months. And we need to think about the context of use. The other thing that we've learned is that conventional CT imaging, here showing the Marshall grading of the CT as a space-occupying lesion, is fantastic for planning surgery and deciding whether there's a neurosurgical emergency or not. But however, it doesn't really define or detect prognosis-defining abnormalities. Here, bilateral brainstem injury, contemporaneous CT and MR with a hemorrhage on one side. Clearly, this is what's going to drive this patient's outcome rather than anything in the supratentorial compartment. Similarly, the presence of diffuse axonal injury here, using the surrogate of diffuse vascular injury, is also going to be a very important driver of outcome. And finally, you can actually look at diffuse axonal injury directly using diffusion-weighted imaging or diffusion tensor imaging. And you can see the difference in conspicuity compared to simple CT and how much easier it is to see it on the MR. Now, you can combine the biomarkers and the MR to provide a strategy for how we take care of these patients. And that's based on this. We use these aggressive treatments, hypothermia, barbiturates, decompressive craniectomy, and severe TBI, but it's important to differentiate patients in whom refractory intracranial hypertension is the cause of poor outcome. They come in with not very bad primary injury, but they have rise in intracranial pressure, perhaps because of host responses. And controlling their ICPs is the way to make them better. Or if you have patients who have terrible brainstem injury, terrible diffuse axonal injury, and the ICP is just someone carving their tombstone saying this patient is going to do really badly, then actually using decompressive craniectomy is a way to ensure very poor quality survival. And as I've shown you, MR can define these prognosis-defining abnormalities, but we can't do MR on everybody simply because it's logistically impossible. And there are hazards associated with taking sick ventilated patients to MR. But if you wait until the point at which they have refractory ICP and you want to take them to the MR, those hazards are even more increased. And the question we asked was whether blood biomarkers would identify patients where the CT occult injury was detected by the biomarkers. And the short answer is yes, not perfectly, but in this paper that just came out in Critical Care Medicine, we found that using a range of biomarkers, you could actually enrich a population for MR. You wouldn't absolutely include everyone who needed an MR. You wouldn't exclude those who didn't need an MR, but you could enrich the population and you could balance risk. It's not perfect, but it contributes to decision making. Now, what about the actual thresholds we use when we're treating these patients? Conventionally, we used ICP threshold of 20. Recently, based on some data from Cambridge, it went up to 22. I don't know whether that's really, even though it was based on our literature from the Brain Trauma Foundation, I don't know whether that really is a thing to worry about. But the point is this, an ICP is not an ICP. It depends on what effect it has on brain physiology. And there's an increasing tendency to use brain tissue PO2, brain chemistry, the lactate pyruvate ratio, brain glucose, substrate availability, and an index of autoregulation because cerebral perfusion pressures below the lower index of autoregulation are very harmful, whereas those above the lower index of autoregulation are not so bad. And you can see for each of these there are two thresholds. And the reason there are two thresholds is because the more stringent thresholds, so keeping brain tissue PO2 above 20 to 25, for example, is something that predisposes to favorable outcome. But if you use the lower threshold, it's usually associated with mortality. And I'll tell you why that two-level threshold is important. And these vary with age and gender, particularly for autoregulation. And you can use some of these indices to have individual thresholds that can be set. This is still in the process of being implemented, but there's a lot of promise from using autoregulation-based thresholds. So why do we want these two thresholds? Well, this is what normal physiology looks like for ICP, PRX for CPP opt, which is an autoregulatory threshold, jugular venous saturation, brain tissue PO2, lactate pyruvate ratio, and brain glucose. This is what is desirable. We'd like the numbers to be there. But these are our drop-dead thresholds. Below this, patients are going to really have a bad outcome or die. So having this two levels allows us to choose therapy intensity and only use the hazardous therapies when the ICP is very high, about 25 to 30 millimeters of mercury, or when these other downstream thresholds are exceeded. And this ensures we make the juice worth the squeeze, and we use this to escalate treatment in an individualized way and prevent harm. Now, it's really important to provide one caveat. This evidence comes from association between these thresholds and outcome. And that's a reasonable basis for treatment when nothing else is available to support it. But causality is not proven. There are now trials that are assessing this approach. So BOOST 2 provided some indication about brain tissue PO2 monitoring. BOOST 3 and Bonanza are two big studies that are actually looking at brain tissue PO2 monitored management of patients. And Cogitate is a trial run looking at autoregulation-based management based on PRX. The next question that we tend to ask ourselves is, what about recovery from consciousness? And this is data from the US TBI Model Systems Project looking at patients who left the ICU still in a disorder of consciousness or had woken up. And you can see that the patients who were still in disorder of consciousness were longer in the ICU and more often required a surgical intervention. But the point is this, that if you looked at these patients, this is not obeying commands on arrival in the ED. This is at the point when they went to rehab. And then this is the point at which they left rehab. You can see that 80% of the patients who arrived in acute rehab had recovered consciousness. And in a further analysis, they found that 40% of these patients recovered either partial or full independence. So this tendency to write patients off when they haven't recovered consciousness when they leave our ICU is simply not right. What we can do is to try and find ways to support decision-making there, and this is a really nice paper from Louis Puy-Bassier's group in Paris based on the Center TBI data. And we've known for a long time that quantitative MRI can contribute to decision-making. It works really well for cardiac arrest. But for TBI, because of heterogeneity, it's not been as clean. And what Louis and his group have done is a very sensible thing, which they've provided two separate thresholds, one for favorable outcome and a separate threshold for unfavorable outcome. So you have a green area and a red area and a gray area in between. But what you can do for an individual patient is to say that the likelihood of an unfavorable outcome is so high that that should inform your decision. On the other hand, favorable outcome is reasonably high and that should inform your decision. And using those thresholds would really contribute to our clinical care. The problem is that this requires quantitative MRI. And for some reason, which I don't understand, radiologists don't like dealing with numbers. So trying to implement this is going to be a bit of a challenge, but we have to because it will inform our decisions. And regardless of whether you want to withdraw treatment or not, we should be using interventions that allow arousal in these patients. And we have good evidence for this one drug, which is a amantadine antiviral drug, but it is both a presynaptic and a postsynaptic dopamine agonist. And this trial run by Joe Giacino now more than 10 years ago, what they did was to use either amantadine starting at 100 milligrams BD and then escalating to 150 or placebo for 4 weeks and then a 2-week follow-up. And their outcome was the disability rating score. The higher the score is, the worse their disability. And what they found was the recovery was faster in the group treated with amantadine. You can see that it comes down. This is the point at which the treatment is stopped. The patients who are on placebo also recover, but much more slowly, and they catch up by the time you get to 6 weeks. So the message is that amantadine and the other arousal agents under investigation they probably do eventually make a small difference or an uncertain difference, we have to find out, in the eventual arousal, but they will certainly accelerate it in a subset of patients, and using it may allow us to make those decisions much more easily. The last question is, how long do you wait for? I said you should look at least 6 months, but this is data from the Rescue ICP study run from Cambridge, now following patients up to 24 months. And I've rejigged the data from the paper in JAMA Neurology to put the surgical arm at 3 points together and the medical arm together. And what you can see is both for good recovery, so Glasgow Coma score, so outcome score 7 and 8, and for dead or disabled. So left of the black line is dead or disabled, right is independent. You can see that for the medical arm, after 6 months, there's very little increase in improvements in outcome. But the surgical arms progressively go on to have additional improvements in outcome. We don't know the biological basis for this, but it makes it clear that when we are judging the results of something like decompressive craniectomy, I don't know whether this applies to deep hypothermia and barbiturates as well, waiting 6 months may not be enough. We have to wait at least a year, and we may have to wait 2 years. Now, that's a difficult thing to do because at the same time, as you're achieving these good outcomes, you're also consigning a substantial proportion of the additional survivors to very severely disabled outcomes. And there are philosophical and also ethical questions there. So individual choice becomes very important, and a discussion with the family is important. So we now have a set of additional things that we can think about: age and frailty. Wow, okay. Age and frailty, and all of these things to go through. I'll have to go through the remainder part of this very quickly. But there are some future questions to think about, and they include genetics. We know that 25% of the outcome from TBI is probably heritable. They also include the association of genetics with outcomes. This is outstanding work from Pittsburgh, from Ruchi Jha and colleagues, showing that the SIR1 receptor and the variations in SIR1 receptor are important both prognostically and may be important in allocating patients. Blood biomarkers, particularly of the host response, these are innate immune markers from a variety of people from the States in the TRACK TBI pilot study, may allocate patients to post-inflammatory or hyperinflammatory groups. And these may be actually useful to identify patients who are likely to respond to therapies. And I might spend just 30 seconds on this. This is a secondary analysis of the PAMPA RCT, which was fresh frozen plasma in patients at high risk of hemorrhage after trauma. There was overall 10% improvement in mortality reported in the NEJM. And then in a subsequent paper in JAMA Network Open, they showed that all of this benefit was in the TBI population, and the effect size was 20%. And what they did was to undertake a multi-omic analysis, showed that you had 2 endophenotypes, and that those endophenotypes had very different outcome characteristics. But the benefit from the intervention was only seen in the poor outcome endotype with TBI. So this was an interaction of pathoanatomy and also multi-omic endotype. So I'll move on, I think, because we're tight for time. And I'll summarize this. Can I go back one? Yeah. So we've talked about what we know now and what we're doing currently here in blue. The gray is evidence that's continuing to accumulate. And here we have what's coming our way with genetics, injury markers, and mediators, and advanced imaging. And this should allow us to provide a more sophisticated solution to managing our patients. Thank you.